Welcome to the Hot Topic series. My name is Marta Borfito. I'm a consultant physician in infectious diseases and HIV medicine at Chelsea Westminster Hospital in London. It's a great pleasure to present Dr. Andy Ustianowski, who is a consultant physician in infectious diseases in Manchester, who is going to talk to us about late presentations with HIV infection, which is indeed a very important topic because it is something that we should try to prevent and avoid if it's possible. Andy, please.
Well, thank you very much, Marta. As you said, what I'm going to be talking about is late presentation in HIV. And this is the outline. What do we mean by late presenter? How big a problem is late presentation? Who is it that presents late? What's the impact? And most importantly, what can we do about it? So in terms of how do we define late presenters, this has changed a little bit over the last 20 to 30 years. But the current definitions really revolve largely around a CD4 count at diagnosis of less than 350 or an AIDS-defining event, regardless of the CD4 count. But there are some problems with these definitions. An AIDS-defining event can be very late. And if we're talking about the CD4 count cutoff, well, those with early HIV have a very labile CD4 count, and quite often a low CD4 count can be recorded. So you can see in the graphics there that actually true late presenters may be a little bit less than we get just purely looking at the CD4 count criteria. How big a problem is it? Well, the last data we have that's reliable in Europe is from 2018, showing that really one in every 2 individuals is presenting late by these definitions. And within Europe, there is discrepancies. There are differences between different areas and different countries, and also some countries where actually we do not have robust or good data. And which individuals are they in Europe that present late? Well, here you can see that it's particularly the elderly, particularly heterosexual men, and some of the ethnic minority groups within our populations that seem to present later than others. What I want to focus on really is some of those factors. So what about the elderly? Well, I think in the elderly, it's perhaps because they're not perceived at being at risk. And here we have some data showing that really the rates of AIDS diagnosis at diagnosis of HIV are really doubled. And the other groups where I think we are late in diagnosing, more for structural reasons, is certain subgroups that are disenfranchised. And I particularly want to focus on refugees and migrants who often have poor access to testing and poor access to healthcare in a variety of our areas. So what about the impacts of late presentation? Well, if you present late, you may well have an opportunistic infection, which in itself has morbidity and occasionally mortality associated with it. But along with opportunistic infections comes along different therapies and polypharmacy. And it is not unusual to have someone on treatment for pneumocystis, tuberculosis, CMV, cryptococcus, all at the same time. And what about the antiretrovirals? Well, antiretroviral therapy is recommended for all adults, regardless of CD4 counts. But for some individuals, we or they decide to take time to come round to antiretroviral therapy. There could be a pre-contemplation phase, a contemplation phase, a preparation phase, and then ultimately action. But those that present late really should have their antiretrovirals commenced without delay. There are some perhaps exceptions to that. CNS opportunistic infections such as cryptococcal meningitis, CMV, or perhaps even tuberculosis, we may want a slight delay in commencing antiretrovirals. And what are the impacts? Well, there is an impact directly on mortality. Here's some data showing that really there was a 7 to 8-fold increase in mortality amongst those who present late rather than those who present early. And this may be old data, but I still like it. It's based on a Danish cohort looking at life expectancy in those with HIV compared to the matched population. And I hope you can see that group 1, HIV itself, is no real difference from the general population. But if someone has alcohol or drug abuse, if someone has significant comorbidities, or particularly important here, what's called risk factors, and risk factors are really late presentation, that long life expectancy is no longer apparent. Are there impacts? Well, we can get immune reconstitution, which is really an overwhelming immune response to antigens. And that is more common in the late presenters, and particularly those with opportunistic infections. But I also want to focus on inflammation more generally. So inflammation may well be the cause of a lot of the issues we have with those living with HIV now. It could be what produces an increased rate of cardiovascular disease, pulmonary disease, arthritis, cancer, diabetes, metabolic syndrome, etc. And late presenters almost certainly have a higher degree of background inflammation, whether that's due to leaky guts or whether it's due to other factors, isn't entirely clear, but it does seem to be that there is a correlation. And what about the excess morbidity and the excess mortality? Well, here we can see some data across Europe looking per million of inhabitants in each country, how many people have that excess events. It isn't just patient-focused impacts. There are also impacts on our health system and on our communities. Some data from Italy showing that really there is a significant increase in cost to the healthcare systems or cost to the individuals in certain of our settings in those that present late rather than those that present early, particularly in the elderly. And in terms of U equals U, having someone who's presented late means they've had a longer period of having a detectable virus and therefore may have transmitted the virus to others. So what can we do about late presentation? Well, there's a variety of educational and other resources out there. One of the key things is what we call indicator diseases. Now, these can be those diseases that are really strongly associated with HIV, such as pneumocystis, Kaposi sarcoma, etc. But they also include illnesses and diseases that are more prevalent in the general population than Kaposi sarcoma or PCP. For instance, lymphomas. For instance, thrombocytopenia, and then quite common diseases such as bad psoriasis or bad seborrheic dermatitis. All of these are potential indicators that someone might have HIV and should really lead to an HIV test being performed. But having said that, actually we're not doing that well. If we look at what's called medical missed opportunities, most of the people who present late, when you take a history from them, they've had multiple interactions with healthcare professionals over the months or even years prior to the diagnosis, sometimes or often with conditions that should have hinted at someone doing an HIV test. So data on the left from the UK says that those presenting late, over 50% of them had interacted with general practice with illnesses or with symptoms that could suggest an HIV test was indicated. And over 50% had an indicator condition. And on the right, we've got some data from Denmark showing that actually the prescriptions of just general antibiotics in HIV individuals compared to non-HIV individuals in the 3 years before their diagnosis was different. So maybe we can pivot on factors such as this. So what potential interventions could we think about doing? Well, healthcare professional and community education, the indicator diseases, how to access HIV testing and care and advice, etc. Opt-out testing at general healthcare settings, generally in terms of those admitted to hospital. In our unit, we've been testing everybody who comes as an inpatient for the last few years, regardless of whether you're a 20-year-old MSM or a 95-year-old lady with cellulitis. Opt-out testing for the indicator conditions. What about case note prompts? For instance, if you have bad psoriasis, if you have thrombocytopenia, are there prompts that can be put within often electronic patient records to encourage people to be tested? And what we're doing, and certain other sites are doing, is reviewing all late presentation cases, doing a root cause analysis, looking at who they interacted with, and spreading that information. If they've been to see their general practitioner, we contact the general practitioner, advising them that this individual is now diagnosed with HIV, with the individual's consent, and exploring whether an HIV test would have been appropriate at their previous interactions. But there remain barriers to HIV testing that we need to be aware of. So barriers at the individual level. There may be a low risk perception. There may be low knowledge of HIV and the benefits of treatment. There may be a lack of information and signposting to how to get a test done and where to access this. And importantly, stigma and concerns about confidentiality. At the healthcare provider level, there can be lack of training on how to undertake a test. There can be lack of knowledge about the indicator diseases or about HIV per se. And there can be discomfort about approaching individuals asking about HIV and sexual histories, which interestingly, in almost all surveys, is a healthcare professionals issue rather than a patient issue. The patients have very little discomfort about being approached about these subjects and often think that an HIV test is being undertaken anyway. And then at the institutional, the regional, the national level, there could be a lack of or poorly implemented policies about testing for HIV, lack of allocated resources, and there can be for certain subgroups in our populations, for instance here, migrants and intravenous drug users, some legal or financial obstacles to accessing care. So in conclusion, late presentation remains a very significant issue. A lot of people present late, and this has impacts on mortality, morbidity, costs, increased risk of transmission, etc. Some subgroups in our populations are more likely to present late than others. And there are multiple reasons, a variety of levels for late presentation. And we really need to address all of these different issues with multiple initiatives if we're going to sort out this issue.
Thank you, Andy. That was really great. So you discussed about group of people who seem to be seen as presenting late more frequently, and also certain medical professional that might be a good opportunity for not missing an HIV test. So can we just discuss which medical professional do you think we should target for education on late HIV presentation?
I think that's a really good question. And actually, I think we've been targeting the wrong people. What we've tended to do is prepare guidelines and do education that's focused towards those that already look after those individuals with HIV. But those missed medical opportunities are largely primary care and other physicians. So I think primary care is an obvious one. I think people attending accident and emergency departments, people admitted to a routine hospital ward with a bad pneumonia, all of those are indications for an HIV test, but it's the professions in those wards that we're not necessarily focusing on. But actually, if you look down that list of indicator diseases, it is hematologists, it's rheumatologists, it's dermatologists, it's a whole variety of different people. So I think we actually have to put the education out there much more broadly than we have already if we want to make a big difference.
Thank you. Yes, I hope you don't mind me adding gynecologists and obstetricians. I know that pregnancy HIV testing is done and is a very important tool that has been implemented into clinical care. But I think that sometimes women are not tested early enough. And this is, I think it's quite important from an education point of view, because it might be easier to miss a new HIV infection in a woman than in a man.
Absolutely, I agree completely. And there's plenty of data that those attending colposcopy clinics and other settings have a higher rate of HIV than the background population. So absolutely.
So have you seen any initiatives which are making a difference?
I have. I mean, all initiatives are going to be setting dependent, and not every initiative in one place can be transferred easily to another place, but at least we should consider whether it could be. So the initiatives that I think have made a difference are opt-out testing for general medical and general surgical admissions or people attending accident and emergency, prompts on electronic patient records for indicated diseases, and also some more innovative plans and projects. For instance, there's been a project in London that looked at blood tests performed in the community for those who might have glandular fever and running HIV testing on those samples as well. So I think we do have to think multiple initiatives, multiple ways, and I think there's plenty of evidence base out there now that we can hopefully plug and play to our settings.
That's very useful, yes. And I think one of the challenges is probably to implement them everywhere. And you mentioned there is one initiative in London. You are aware and probably part of the implementations of initiatives in the north of England. I think it's very important that education is available for everyone all over Europe, all over the world, so that this can be again implemented everywhere and HIV infections are not missed. So the reason why I believe this is really important is because I wonder whether there is a role for stigma, HIV stigma, affecting access to testing. What do you think?
Oh, I think undoubtedly there is. I think it's a very good point. You know, there are barriers at all these different levels, whether it's an individual level, a healthcare provider level, or institutional and governmental levels. But if we look at the individual level, I think to me there are two main things. The first is perhaps people don't perceive themselves at risk and therefore aren't thinking about getting an HIV test. But actually, even those that perceive themselves at risk in a lot of the settings around Europe and around the world, they are hesitant about having a test because of perceived or actual stigma and discrimination and confidentiality issues. So we really need to sort that out in all of our settings if we're going to be able to make a difference here.
I fully agree. It's interesting how much we are talking about COVID testing and how many people are testing for COVID to protect other people not to get infected, and how simple it is to talk about COVID testing because there's no stigma. It should probably be the same for HIV. It would probably be much easier to test, much easier to treat, and much easier to prevent new HIV infections.
I mean, I think that's undoubtedly true. It can be difficult to approach stigma, but that shouldn't put us off it. We need to all chip away a little bit all the time to make a difference. We're not going to get rid of stigma overnight, but we can all do our little bit, and that makes a big difference to our populations.
And would you agree that with the modern antiretroviral therapies, it's actually easier to start antiretroviral treatment?
Yeah, I definitely would. You know, I started working in HIV in the 1990s. And then it did take a while to get people onto antiretroviral therapies, getting them ready for antiretroviral regimens. And that was really the side effects that we were getting with those regimens, the sometimes complexity of those regimens, multi-tablets, twice a day, even 3 times a day, etc. Now we've got into an era where the drugs are simpler to provide, simpler to take in terms of requirements with food, without food, timing of the day, forgiveness, side effects, etc. So I think we can start people more easily, and particularly in the late presenters, we can start people quicker than perhaps we would have done before.
Thank you very much, Andy, for the wonderful talk and for the discussion. Goodbye.
Thank you very much.